My name is Fariba Badrzadeh from the University of Maryland, Baltimore. Today I will present our work entitled Association between Gas-free cerebrovascular reactivity and cognitive function in older adults with a high risk for vascular dementia. Small vessel disease-related vascular contribution to cognitive impairment and dementia are a major driver of cognitive decline in older adults. Up to 80% of patients with Alzheimer's disease show some degree of vascular pathology. Therefore, there is a strong need for non-invasive biomarkers to characterize vascular pathology. Cerebrovascular reactivity, which reflects the ability of cerebral blood vessels to dilate in response to stimulation, has emerged as a promising biomarker for assessing vascular cognitive impairment. Previous marked VCID studies have reported a positive correlation between CVR and global cognition assessed by the Montreal Cognitive Assessment in both single-site and multi-site settings. In these studies, CVR was quantified by the MRI signal changes associated with CO2 gas inhalation. However, administration of the hypercapnia challenges require access to gas delivery system, which limits its application in standard clinical setting. Therefore, the present study aims to investigate whether CVR measured by intermittent breath modulation without hypercapnia gas inhalation can be a sensitive biomarker in VCID. We recruited participants using the VCID clinical protocol, and we intentionally enriched the cohort for vascular risks. We excluded individuals who had neurologic or medical conditions not related to small vessel disease. All participants completed a comprehensive clinical and cognitive evaluation following the VCID protocol. Global cognition was measured with MoCA and composite cognitive score. The 4 cognitive domains were also evaluated. Physical function was evaluated using gait-speed and chair stand tests. A composite vascular risk score was used to measure vascular burden. CVR was measured in each subject using an intermittent breath modulation that does not require gas inhalation. During this task, subjects breathe at their normal pace most of the time, similar to a resting state fMRI scan, except for a brief period when pacing instructions breathe in and breathe out are displaying on the screen. These paced periods last 12 seconds and occur after every 30 to 60 seconds. BOLD data are acquired during the task using a 3 Tesla scanner with the HCP protocol, and end-tidal CO2 can be recorded using a nasal cannula and capnograph. Data analysis followed previous literature. 82 elderly participants were enrolled in this study, but data from 14 participants were discarded due to technical issues or unusable CO2 recordings. Characteristics of the remaining 68 subjects are summarized in this table. As intended by our study design, the cohort was enriched for vascular risks. Cognitively, the average MoCA score was around 22. This figure on the left shows the result from one representative participant. During this scan, there were 7 brief breath modulation periods. The end-tidal CO2 level shown by the orange line dropped following each breath modulation period. The ET CO2 changes were closely followed by BOLD signal changes shown by the blue line. The resulting CVR map is shown below. This figure on the right shows the group average ET CO2 signal. The intermittent breath modulation resulted in 2-3 mm mercury reduction in ET CO2 across all subjects. Among 68 participants with 30 normal, 29 MCI, and 9 mild dementia, lower whole brain bm-CVR was significantly associated with worse diagnosis after adjusting for age and sex. When MCI and mild dementia were combined into an impaired group, bm-CVR remained significantly lower than in the normal group. Across all 68 participants, we found whole brain bm-CVR value was associated with global cognition measured by both MoCA score and composite cognitive score after adjusting for age, sex, and years of education, where higher bm-CVR is associated with better global cognition. Among the 4 cognitive domains, whole brain bm-CVR was significantly associated with processing speed and language. bm-CVR also showed a trend of association with gait speed, but not with chair stand performance or vascular risk factors. Among different brain regions, we found that regional bm-CVR was positively associated with the composite cognitive score in all regions, although the association was only significant with MoCA in the temporal lobe. Among the cognitive domains, bm-CVR in frontal, parietal, temporal, limbic, and basal ganglia regions was associated with processing speed, and bm-CVR in parietal and temporal lobe was associated with language. In this study, we showed that lower bm-CVR is associated with worse cognitive function. These findings is consistent with prior CO2 inhalation and breath hold CVR studies, which also reported reduced CVR in individuals with cognitive impairment. From a technical standpoint, compared to the CO2 inhalation and breath hold methods, breath modulation CVR is easier to perform, more comfortable for participants, and provides absolute quantification of CVR, making it a practical and clinically appealing alternative. In conclusion, we can say CVR can be measured using intermittent breath modulation without CO2 gas inhalation in older adults with VCID. bm-CVR appears to be a sensitive biomarker to detect cognitive impairment associated with small vessel disease. The new gas-free CVR method may be a more practical approach than the CO2 inhalation CVR method for characterizing vascular pathology in large-scale multi-site studies of VCID.